Chapter 19, Treatment, Prevention. I always remember as a kid, my mother saying that prevention is better than cure. She meant that you could think before you act, and then you will have not to cure anything. I wonder how true this is in mental health. I'm going to make the working supposition that it is, but let's be very honest with ourselves. We have no real proof this is so. It would seem that, in medicine, we are dealing with probabilities and not certainties. As you will see later when we discussing psychiatry and the law, this leads to a great deal of difficulties between the two professions. However, if we are to believe that a breakdown is an accumulation of certain events and tendencies, then we surely can alter our tendencies. But, first let's take a mathematical model. I can imagine your eyes clouding over. Bear with me for 2 paragraphs. Suppose that in any given stressful situation, a person will have a 50-50 chance of breaking down. It's safe to presume that in the patient's lifetime, the occurrence will happen more than twice or 3 times or 4 times, and eventually, like tossing a coin, the event will give rise to a breakdown. Let's suppose that the tendency is 1 in a million, yet, we have so many stressful factors in our lifetime that it is inevitable that, at some point, we may meet that 1 in a million stress. Let's say that the tendency is 1 in a million and the events are many millionfold. We are pretty sure to meet up and crash. Let us suppose that we can alter the tendency from 1 in a million to 1 in 2 million. Theoretically, we are having the chances, but only if the incidence of lifetime stresses is in the low millions. If they are not, then for those who are lucky to meet between 1 million to 2 million stresses, we have reduced their chances to 0. But the vast majority will pass the threshold in their lifetime. For a few percentages of people, we will have prevented the illness. But, for the vast majority we have not. What would seem to offer a 50% improvement in reality will do far, far less. Now, let us consider cost effectiveness and consider whether for a low percentage improvement, is it worth all the bother? In my opinion, the answer most definitely is yes, because the interventions will not only reduce the chances of illness, but most certainly will increase the quality of life. If you remember, I said that tendencies, even if they are not fulfilled for mental illness, significantly diminish quality of life of the bearer of the tendency. So, the intervention will have an intrinsic spin-off in quality of life for all. It's all about theory and practice. You got this far, you deserve a joke related to the subject. A kid asks his dad what is the difference between theory and practice. He tells his son to ask his wife, the kid's mother, if she would make love to the neighbor for $100. The baffled kid comes back with a positive answer. Even more perturbed at his father's request, he asks his sister and comes back with the same answer. But Dad, what has this to do with my question? Well, you see, in theory we have $200. In practice we have a problem. So often, a great theory will leave you, in practice, with a big problem. There are 2 kinds of prevention. The first kind of prevention is to prevent an illness from occurring at all. The second kind is to prevent the illness from reoccurring. I will discuss fully the reoccurrence of the illness and its prevention in the sections on psychosis, neurosis and personality disorders. Prevention of mental illness and mental distress from making its first appearance is a much more difficult subject. We know that 8% of the child population anywhere is at risk. The risks are genetic disposition, poverty and poor parenting. It is very easy in a well-organized community, at the level of the municipality, to spot every one of these cases. It does mean, as we will discuss later in the health services section, that we must build a full integration and workable interface between all community services. In the day and age of data handling, this is no impossibility and relatively easy to do. This involves a social environment at the municipal level led by the municipal leader, who believes in this intervention and overcomes all the political difficulties. Not only that, the municipality leader probably will have to handle the funding. I will discuss this later. At the level of the kindergarten, we fully expect to see children who are already exhibiting problems. They will be exhibiting difficulties in interacting and in impulse control. This will be epitomized in their behavior. These are the kids that will go on to develop illnesses and disabilities. If the medical services, especially the mother and child care services, are integrated, this service information will be swapped readily. It is my opinion and experience that a child in distress will appear in more than one community service. If he is not represented in the community services, then the family most certainly will be. The approach should be holistic and family-orientated. In other words, we should be looking at what the strengths are and what the weaknesses of the family are as a unit. How can we strengthen community services in order that the child will feel in a constant, uniform, caring environment which is conducive for development of his ego in a healthy, normal way? The most important thing that is to be said is that spotting the child is relatively easy. The so-called workers on the lowest rung of the ladder are the ones who generally have the most experience and yet have the least ability to communicate. Frustratingly, the primary caregivers are least expected to communicate. They should be listened to carefully. In all probability, they've seen it all before and they bring with them a very healthy modicum of common sense. The interventions should be at the appropriate level, playing into the strengths of the family unit and not according to the textbook, but according to the needs of the family. We have discussed up to now, prevention of the severely mentally ill. Let us continue with this group. There are several forms of preventive medicine. The first form is to prevent the illness itself, which we have discussed above. The second form is to prevent the illness from reoccurring when it has occurred for the first time. It is essential to understand that any person undergoing an acute psychotic breakdown has already shown that the tendency exists, and we know that it is most likely to occur within 1 year. We also know that if you can stretch the break after the first psychosis longer than 5 years, you have a pretty good chance of preventing it altogether. In real terms, this means concentrating on this patient. The first psychosis, in the first year after hospitalization, should be and must be our prime target. If we were taking in probabilities of 8% in population of severely disturbed children who will amongst them develop schizophrenia, here we are talking about a smaller population with an almost 100% liability if they are not treated and supported. How do we do this? There are two answers. First, the patient must be made aware of exactly what can happen to himself and what the possible treatments are for the patient. The second part of the answer is to make damn sure that the services are arranged so that they know how high a priority it is to service these patients. Tertiary prevention is spotting the environment where the patient lives and supporting it. There are two reasons for doing so. We want to make the supporting system as strong as possible and we want to prevent any illness occurring because of the stress induced by having a psychotic member of the family. In the next chapter, we will be discussing treatment for psychotics and all the provisions especially important for the 1 year post-psychotic and even more so, for the first episode post-psychotic in his first year after hospitalization. Of course, psychotics are the most important part of any mental health service provider's problems. But they are not the only problems. Modern statistics say that 20% of the population anywhere will have a major depressive episode in their lifetime. I'm not sure how true this is, but I would say that we do know when a person is in early adulthood, whether he is liable to develop depression. There are two kinds of depression, and I resort to the old kind of nomenclature describing them as psychotic depressions and neurotic depressions. The psychotic should be treated exactly as any other psychotic. They can be detected as having tendencies to the illness. Most of them will exhibit mood swings. Just as likely as they are to become depressed, they are as likely to become manic. There is one important provision. People who are liable to develop a full-blown manic depressive illness often behave like narcissistic personalities. If you remember, narcissistic personalities have mood swings in accordance to their estimation of their worth. In their case, a highly inflated worth. When faced with a person with mood swings, one must differentiate between what we call a cyclothymic personality and a narcissistic personality. Two important differences are that the narcissistic personality will exhibit other characteristics particular to this kind of personality, in particular very bad tempers and given to acting out. If you look carefully, you will see that the mood swings depend on what is going on around the patient and can change dramatically and very quickly. The cyclothymic personality, on the other hand, does not tend to exhibit temper tantrums nor do they exhibit mercurial changes in mood. Their mood swings can last days or even weeks, but certainly not hours. Why am I saying this? One of the most common mistakes we see in general practice is that the patient who is cyclothymic comes to his doctor complaining about being sad and is diagnosed as being depressed. Without testing to see if this is a cyclothymic personality, The doctor will usually prescribe antidepressants and throw the patient straight into a manic episode. Whilst we are on the subject about giving antidepressants as some kind of elixir for better life, we should remember that a lot of people who are depressed will not talk about their suicidal ideation, and on being given antidepressants, will receive the drive which they did not have before and could well kill themselves. In fact, they often do. Whilst this may sound draconian, it is my firmly held opinion that if a general physician feels that he is to prescribe antidepressants, he should either have a firm grounding in mental health or refer the patient to a mental health professional who can ascertain mood swings and their significance, and any lurking suicidal ideation. Let us go back to discussing the large proportion of the population who are, at some time in their life, going to suffer from depression or anxiety. These conditions I call neurotic disorders. About 33% of a doctor's workload consists of these patients. It is a common aspect of all people to try and explain why they have something instead of describing what they have and leaving the professional to make the diagnosis. With the advent of Prozac, we saw a new advent in marketing. Until Prozac, the targeted market was the physician. This in itself is questionable, but with Prozac, the end user and target was the patient. Doctors were placed under an enormous amount of stress by the patient to be given this new wonder drug, and ever since, this has become accepted practice. As you will see later, with the advent of socialized medicine, third-party payment, the doctor is under a lot of pressure to get the patient out the door within a very short period of time. Very often, the doctor succumbs. This is even more pronounced when the doctor himself is under pressure from either the pharmaceutical industry or his own organization to give the drugs, as it's the best thing to do. In fact, it often isn't, and it is probably the worst thing to do in a lot of cases. We will discuss this more fully when we talk about treatment for neurotics. If you remember, when discussing neurotics, I stated quite clearly that what we should do is to try and calm them, then deal with the underlying personality that finds it difficult to cope and will decompensate into the neurosis. I think it is essential to try and change the way people cope. What are their goals in life and in general? It is to see a world which is less and less driven, and we should be trying to live in a more relaxed environment. I know this is far, far away from the realms of psychiatry, and as I have stated often, psychiatry should have nothing to do with politics. So, I will suffice by leaving this point right now. We do know that there are certain events that are particularly hard to cope with. Birth is one such event, as is the death of a spouse, retirement, unemployment, and of course, natural disasters. For the vast majority of these events, you will see that the stressor is immediately discernible when it occurs. Preventive common sense interventions are not only desirable, but essential. If we are to have social services, and we do need social services, then their activities must be delineated by finite priorities. As I will discuss later in services, there should be an integration between the social services and mental health care. Prevention in medicine is a badly neglected subject. It's not sexy, and it doesn't pay anybody. Nobody makes a lot of money out of it, and nobody is going to have the research funded by doing it. The surroundings are not in the hospital, so there are no extra salaries for night duties and being on call. In other words, we have a very good reason for not doing preventive medicine. This is especially so in psychiatry and is particularly disappointing, because as I say so often, and particularly in psychiatry, what you cannot prevent, you will not cure. If I could prevent one illness, it would be psychoses. But, we cannot, so we will discuss how we may treat it. Let's take this slowly. If the patient is prepared to tell you that what you are saying when you are quoting them is completely incomprehensible, then you have two options. The first thing I do is to tell the patient that, if you think that if I were to say that, then I am completely wrong, you must realize that when you tell others, they think you are too. There is an agreement at this point, generally speaking. We make an agreement that, at this point, we agree to differ, but it is essential for the patient not to divulge to others what he's thinking. You are beginning to build up an alliance where the patient can tell you, and you have advised him not to tell anyone else. This is part of his beginnings of the coping strategy. This step, in itself, can bring him to a point where the psychotic input will wane in time or at least be controlled. You can reinforce the reality testing by, in time, repeatedly asking the same question. If I were to say what the percentages are that I am right, obviously patients are going to tell you that the percentages are low. On the other hand, Obviously, the chances of him being right are 100%. If you remember, we spoke about the inability to accept uncertainty. The psychotic no longer has to face uncertainty. But, when you are on good terms with the patient, you can ask him how he explains the difference without challenging him as if he is lying. You should never challenge the patient's reality. You can challenge his reality testing by asking him, what are the chances that you are wrong or I am wrong, if I were in your position? Another way I have tried to intervene with patients' cognitive processes is more difficult. When the curtain is completely destroyed or very much destroyed, I try to control the flooding of thoughts from the non-aware to the aware by teaching the patient to try and concentrate on one particular aspect. Not to test his reality testing or challenge reality testing as we did before, but more to tell the patient how overwhelmed you are by the streams of thoughts and ask him if he's not feeling the same way. Just being with the patient and not leaving him alone in this situation is the beginning of the building of a relationship between you and the patient. Let us briefly examine hallucinations. There are two kinds of hallucinations, just the same as there are two kinds of thought disorders as we have discussed above. There are hallucinations where the patient is so overwhelmed he has no control whatsoever over what is happening. There is no avoiding medication, and I would be lying if I were to tell you that medication is a guaranteed success. It often isn't. Nevertheless, if the patient is completely overwhelmed by her or his hallucinations and, in particular, if the hallucinations are giving him commands, we have very few tools in our toolbox. What I try to do with a psychotic who is hallucinating is to give him some sense of control. I think it's very important to ask the psychotic if he wants to hear the hallucinations. One of my most favorite patients told me that his best friends were the voices he heard from outer space, and he wanted to hear them. I digress. As an author of fiction, I can tell you with no doubt that the intricacies and productivity involved in hallucinations can be of the richest quality. When we give the patient medication, we often rob them of an entire rich world which they happily live in and condemn them to chemical straitjackets with the most awful side effects. The patient is allowed to choose with whom he wants to talk, and that includes fantasies and hallucinations. I will never forget the patient who told me, I went into hospital thinking or believing that people were controlling my thoughts. They stuck a needle into my backside and controlled my thoughts for me. But I really gave up when one day, my eyes shut up and I was staring at the ceiling all the time. This is a common side effect of antipsychotic medication. I went to see the duty doctor who was playing backgammon with a nurse. Without looking at me or stopping the game, the doctor ordered me to have another injection, and suddenly my eyes were back under my control. I ask you, Dr. Benjamin, what kind of lunatic world is this where I get hospitalized because I think people control my thoughts, and they do, and they take over my eyes for me? Getting back to the subject matter, always a difficult thing to do. Let's suppose that the patient finds the hallucination tedious, and they would prefer not to have them. There are simple things you can do, like listening to a Walkman or simply flicking your hand with your fingers of the opposite hand. This will distract patients enough that the hallucination stops. In the beginning, hallucinations will return immediately, but nevertheless, the fact that the patient can begin to gain control and mastery is the beginning of a time when he gains some mastery over the disease. E's story says so much. E and I started in psychiatry at the same time. We were just on different sides of the desk. As I started in psychiatry, E became a patient. We met often, and when I was managing a community care center, I often asked E his opinion about a lot of things and therapies. I learned a lot about managing a healthcare system from him. E told me this, "Doctor, you are an avid Leeds United supporter. Everybody knows it, and if you were just to think about Leeds United all the time and not do anything else, you would be ill, wouldn't you?" Well, it's the same with me. I believe I'm God. I know you think it's crazy, but you have no right to tell me what to think and what to believe. I know I am. If I do not function in my day-to-day life, it is because I am so busy thinking about the fact that I am God. You know, my son is a rabbi, and when I visit him, I believe his congregants are praying to me. It's my right to think that, and I know if I were to tell them that, it would be very bad because they just would not understand. If I were to tell them that, they would believe I am ill. In other words, by telling them I am God means I am ill. E helped me understand that beliefs and belief systems are entirely up to the patient, and we have no right whatsoever to interfere with them. All the patient asks is for us to handle his belief system, which we call psychosis. He doesn't. In order to do this, he decides when and how to take medication. I learned from him that all patients take medication as they see fit, and it is not to overcome the thought that we consider to be psychotic or the hallucination. They want to hear the voices if they are pleasant, and avoid being hospitalized. Patients want to function with their lives as they see fit. I was then told something which absolutely amazed me. E and DS both said that, in their opinion, once a patient had his belief, what we psychiatrists call a delusion, the patient simply learns not to tell the psychiatrist. The act of telling the psychiatrist means that he is ill. I will discuss this later in the chapter. Let me give you one more description where psychotherapy without medication had an amazing effect in treating paranoid patients. Treating these patients is never easy. The first thing you must always remember with a paranoid patient, as with any other patient, is not to challenge his delusions. The second way is not to deny and accept to a certain extent that the patient will always feel that he is being persecuted. All these patients want to do is to find some kind of shelter. You have to avoid the situation with a paranoid patient where he may seek retribution. If somebody tells me that paranoid ideation has ceased, I tend to assume that I am no longer in full contact with the patient. The ideation may be hidden deep down and dismissed in its importance. In E's words, the thought is there, but they are no longer acting on it. It is part of their non-aware conscious. At this stage, we should try to let sleeping dogs lie. I want to tell you about a patient whom I found fascinating. The patient had been injured in the war. He could not ejaculate and his sperm entered his bladder. The only way that he could get his wife pregnant was by artificial insemination. The man was a religious person and he came to be convinced that the son his wife had born this way was illegitimate. I used his paranoid style to interfere with his paranoid ideation by using the "what are the chances that" technique. He was able to live with the fact that he was probably wrong and the paranoid thought subsided. One day he came to me in frenzy of fear and agitation. It turned out his wife had become pregnant without artificial insemination. I have a friend who is a prominent gynecologist and he assured me that if, on prolonged sex, the patient had ejaculated, as he probably had, into his bladder, the prolonged sex would have milked the sperm as if it had ejaculated normally. I realized this explanation was far too long and complicated for the patient to accept. I invited his wife to see me with him. As I stated, they were both religious. I told her, to his great consternation, that I strongly advised her to divorce him. Horror struck. He asked me why. I told him that his wife had gone through all hell to bring one child into the world, and he had accused her of being unfaithful. Now a miracle had occurred and explained how it had occurred. They were going to have a child normally. I told him that he had been blessed and was spurning the blessing, and for this, he would surely be punished and there was no reason for her to be punished as well. He was so frightened by the superimposed paranoid ideation, which was entirely mine and deliberate, that he abandoned his original one. He stated that the child he was having with his wife was indeed his and was a miracle. I do not suggest this way of treating a paranoid patient should be standard practice, but it is an example of how you should utilize the patient's paranoia to keep him in a therapeutic setting. Another example. An American Jewish soldier who was convinced that the American army hierarchy were in fact closet Nazis, and he had to expose them. He was certain that he was going to be killed for his efforts. Instead of arguing with him, I suggested that the best place to hide was in a mental hospital, because nobody would think of looking for him there. I told him that the best way to convince anyone was for him to have treatment, so as to not arise suspicion. He agreed and on taking the therapy, started to calm down. When it came time for him to be flown out, I asked him if he believed everything I said. He said that he did, and I explained that I believed that he had a psychiatric problem that we needed to deal with it. He agreed and was flown out to receive treatment. I greatly believe in humor. I tell my patients jokes and they tell reciprocate. It is a great equalizer. Another is to sit next to them over a coffee table instead of opposite them at a desk. One patient was a stand-up artist. Her patter started by, "My shrink is an avid Leeds United supporter. I always look the results up before my appointment. The season they got relegated, I was hospitalized. He wasn't too far away." I am proud to tell that I regularly gave her ideas for quips, If you care to read one of my 3 novels, Moses, the First and World's Worst Travel Guide, is often the butt of many a joke. As you will have noticed, I am a great believer in making the family environment receptive and accommodating, and talking with the patient about what he wants to hear and is capable of believing in. But always stay within reality. Another line of treatments which I strongly recommend is to use quasi-group-like settings. One of the best methods of maintaining patients is to have a walk-in clinic just for them. In the walk-in clinic, there is an ongoing group. They sit in a group of patients in an ad hoc group setting, where there is one psychiatric or mental health worker of any discipline. There, they can bring up any and every problem they are facing. It is amazing how they can and do support each other and will go look for someone they have discovered is missing. The group has no boundaries in time. The patient can come as often as once and stay for as long as he wants. At the same time, the patient will be offered long-term injection. If need be, they will be advised to see a doctor who can change the treatment regime according to the changes the patient may be exhibiting at that time. The group should never be allowed to get to the position where there is scapegoating or a loss of boundaries, where the patient feels that his observing ego and reality testing are threatened. In other words, the group leader mental health worker should not give interpretations, but explanations, and rely on the group strength to act as a supportive environment. I have said it before in this book, in my opinion, the psychiatrist's blind belief in antipsychotic medicine is an operative delusion, in exactly the same way as the patient's way of handling their delusions. I often feel that psychiatrists need to give medications much more than the patients need to receive them. Thankfully, the patients know how to regulate and avoid taking medications for the whole of their lives, when they probably may well not need them. Are medications the physician's magic blanket that helps them cope? So, when do psychotics need medication? They may well need them all their lives. I often discuss medication with the patient. I am not prepared to bully him or coerce him into taking medication. They often are not taking the medication in any meaningful way. I say this as an auditor who has followed up drug utilization. Most psychotics are taking medications at about 30 to 40% of the amount of what we think they are taking. It is probably even less than that. Why do they need medication? In my opinion, the psychotic is exhibiting a psychosis as a pathological reaction to a pathological circumstance. What is happening? We all react to stress in different ways, but in a way that is particular to us. The psychotic does it by losing his reality testing and entering into the delusional world which we recognize as a psychosis. In the old days, antipsychotics were known as major tranquilizers. I believe they are just that. They dull the environment to such an extent that the patient no longer reacts to anything. We can titrate the dosage so that the patient does react to stimuli in a way that neutralizes the stimulus and maintains their shredded reality testing. Of course, medicating doesn't work as well as we would like it to. What we do see very often is that the side effects are much more pronounced than the hoped for effects. I think it is important that the patient should be allowed to titrate himself. I do this by being very open with the patient and tell him that I am prepared to enter into a regime where he decides what medication he is taking on 2 conditions. The first is he will be completely honest with me. The second is that, if there is any change in his condition, he come and see me immediately, and we decide together what to. Then we reduce dosage to the lowest side effect and optimal therapeutic efficacy. This is a nice way of saying the medication does something in helping to cope. When and what are the changes we will make? The beginning of every acute psychotic breakdown is almost invariably heralded by changes in sleep, and very often, by changes in eating habits. If the patient has more than one night where their sleep pattern changes, they must come and see me. I reassure them, and it is quite true from my experience, that if we act quickly and increase dosage, we can abort the impending psychosis. I explain to them something which is very true. We know that an average of about once a year, a person who has experienced a psychosis will experience events which, if untreated, will hurtle them into another psychosis. If the patient is lucky and in conventional therapy, the medication which has been taken for the prior 11 months will suffice in that 1 month to abort the psychosis. We can titrate so that the patient is taking the minimum dosage during the 11 months. Then, hopefully, we can catch the relapse in the 12th month and effectively abort. We will have a short period of about 2 weeks where we can start and we try reiterating back again. There are some cases where the titration fails. But we do need optimum bilateral trust. You have to remember that the medication has a placebo effect for the patient, the family and the psychiatrist. Often, all need the placebo in place all the time, and if it is not there, then the level of anxiety and pressures will arise, and in my belief, give rise to a psychosis. If it is the case, I feel that you should let sleeping dogs lie and not try to shoehorn your beliefs and needs onto the family and the patient. If they want to take medication, even if they are saying it indirectly, then you should be giving it to them. Let's finish with a joke. One of the wheels on a car falls off. The driver discovers that he has lost all 4 wing nuts on one wheel. A voice cries out from a window in a building behind a wall. Take 1 wing nut from all 3 wheels. Drive slowly with 4 wheels with 3 wing nuts. The driver nods his head in gratitude. Then he asks, "Isn't that a lunatic asylum?" The answer was, "Yes, I may be crazy, but I am not stupid." And your patients rarely are.